Brafford. I'm the chair of Wellbeing Week in Law, and I'm also the vice president of the new Institute for Wellbeing in Law. In addition to that, I'm also a doctoral student in positive organizational psychology. And for about the past 5 years, I've been working with a hospital system to develop their resident well-being program. The medical profession has been studying physician well-being and especially burnout for the past few decades. And so they're far ahead of the legal profession in studying well-being. So there may be some things that we can learn in the legal profession about developing our own well-being programs within law firms and other legal organizations. So I thought it would be helpful to share some of my findings and experiences in working with the medical profession. About 3 years ago, we started a multi-wave study at a large hospital system, and the outcomes we were looking at were engagement, burnout, depression, and also residents' attitudes about returning to their hospital after their residency. The predictor variables that we looked at were first meaningful work, whether the residents experienced their work as meaningful, and also supervisory physicians' leadership style. We also looked at something called psychological capital, which is a mental strength made up of 4 different components, which are hope, efficacy, resilience, and optimism. And what we found is that all of these variables had significant relationships with the outcomes that we were studying. I've created 2 videos to share my experiences working with the hospital system to talk about the development of their resident well-being program and also to share some of our study's findings. In part 1, I talked to Dr. Greg Guldner, who is an emergency department physician in Riverside Community Hospital here in Southern California. And I talked with him about his work on developing the elements of the resident well-being program and also some of the findings of our study. In part 2, in the second video, I interviewed Dr. Scott Rigby, who is a behavioral scientist who specializes in self-determination theory. This is one of the theories that was the foundation of my book, Positive Professionals, that I wrote for the legal profession. We're now using this same theory as the foundation for a leader training for supervisory physicians. And what our belief is that if we're able to improve the effectiveness of the leadership style of supervisory physicians, we'll be able to increase the well-being of the residents that they supervise. Each video is only about 30 minutes long, and I hope you find them helpful.
Hi, Greg. Thanks so much for joining me today. I'm really excited to get to talk to you about what you're doing at the hospital with resident well-being. And could we get started by just having you introduce yourself?
Sure. Thanks, Anne. I'm excited to do this with you. So I am program director for a residency program in emergency medicine. So these are folks who finished medical school and they're now training to become board certified in emergency medicine at Riverside Community Hospital, which is a big hospital in Southern California. And I'm also now the what they call the DIO, which is a fancy term for the person who is over all of the programs at the hospital. So we have 11 programs, 172 residents now, and I'm in charge of them. As well. And then my wife's a lawyer, so that's relevant, I suppose.
You have some insights.
I know a little bit about that world, not much.
I'd really like to hear about how you got started in resident well-being at the hospital. Can you tell us a little bit about that?
Yeah, so, medicine's kind of known for, almost 20 years, probably a little more even now, about a growing problem in both medical education and in medical practice around, usually they use the terms burnout and then depression. And then there's this issue that physicians have the highest suicide rate of any profession too. So it's become quite well known. And back in the, I'd say mid 1990s even, that started to become a little bit more talked about. And then in about 2003, the accreditation group, the folks that actually accredit the training programs, came out and started beginning to push a little bit on requirements to look at well-being among residents in training. And so, of course, that was something I worked a little bit on back in the early 2000s when I was a program director then. Then I went into some private practice a little bit, so left academics. And when I came back, we started a brand new program. I think that's when you and I first got involved with this, We really wanted to start something from the beginning of our program. So before we even had any residents, how do you structure this? And even at that point, I'd been looking at wellness for about 15 years in medicine and had seen virtually no difference. I must say, if anything, worse. People talked a lot about it, lots of studies showing that it was prevalent, but no real differences that I could see on the ground. So I think you and I had talked a lot about what do we need different compared to some of the other stuff that had been out there. And so we had talked a lot about positive approaches to this. I remember, and I was quite confused by that. I recall, as a physician, I'm much more focused on the, there's a disease out there. How do we fix the disease and how do we fix the burnout? And I think you had convinced me that there's probably more to it than just fixing the burnout stuff. And so we started looking at what do we do here to set up a program before our residents even hit the ground. And I think we've done really, really well with that. And I appreciate the input you had.
We met, I think we started working on this 4 or 5 years ago. And so we talked about the elements early on, and I'd love to hear how has it progressed and what are the elements now?
Yeah, it's been a really fascinating journey, and I've taken so much from the positive psychology side of this from you and the Claremont group, and then there've been some other groups out there too. The National Academy of Medicine has worked on this quite a bit, and so I guess before getting into the details, I can tell you that our program in 2018 was ranked #1 among all the HCA programs. So. HCA is a company that owns a lot of hospitals, but we also have the largest graduate medical education program in the US. We have now 300 plus programs, 58 teaching hospitals across 15 states. And so in 2018, which was just a couple of years after we started the program here in well-being, we were ranked #1 in terms of resident satisfaction across the country. And then we replicated that in 2019, almost. We went to #2. That's just regression towards the mean, I think.
Congratulations.
And then, thank you. And then they stopped ranking programs when COVID came out, but in 2020 and 2021, we had every single resident and every single faculty member in our program ranked the program as very positive, a top box rating, and that's really unheard of. So I say that just because some of the stuff I think I'll talk about, and when I present this to other people, there's sometimes this sense of, what are you even talking about? I don't even know what terms you're talking about, meaning and all this stuff. So I would say, your question was, how are we doing? I would say really well in this front. I would say probably leading the pack. And now the question is, can we begin to educate others on this? So, what we do, and when I say we, it's not just our hospital, but now HCA in general, is we kind of look at well-being in a broader sense. I think that's a lot of what the positive psychology has done. So we've really moved away from this, this incessant focus on just burnout. And I do think it's important. I'm not trying to downplay that. I think it's really important to look at burnout and to look at depression, and of course, on the extreme suicidality. But I think you totally miss an opportunity that uses different structures and processes than we do for fixing those burnout, depression things, to really go towards a more robust idea of what well-being is, in terms of we've changed it all to say flourishing, right? So we just call it flourishing. And so what we've looked at now are what we call the 3-pillar approach. So we use these 3 pillars approach to wellness, where the first pillar is really about workplace environment. And so most well-being committees out there focus on what I call the ice cream social model, which is, how many more ice cream socials should we have at a pizza party or a bowling alley? And those are great. That's fine. There's a role for that for sure. But if anything, our wellness committees focus much more on what are the things that are annoying people day to day. So for us, it's things like the computer's not working right, the printer's in the wrong position. For us, the nurses are forgetting to log in, the light above my workstation isn't working. And it's amazing how mundane, I would say, much of what we do is, but it goes in you talked about, I'm going to start using jargon here, jobs demand resources JDR model in terms of workplace. And we teach that very specifically about how do we reduce demands at work, even simple things, and how do we increase resources to people? And so that's our first pillar, is just fixing the work environment. And I would say 80% of our wellness is all around just how do we make the work day smoother for people? And that really pays off. And then the second pillar is, we call it individual capacity. You can call it whatever you want. That's the resilience kind of stuff. And how do you teach people to be resilient? And I would say we move way away from lecturing. I absolutely hate the idea that you can lecture people into being resilient. I think that's really unlikely. So we have this idea of moving away from curriculum towards culture. And by that, we integrate a lot of our so-called didactics, I guess, on well-being into day-to-day activities. So everyone does have to have some general shared beliefs about wellness. So we do actually have some didactic about what does wellness mean. We talk about the Perma model that comes up in positive psychology. We talk about the differences between trying to fix things that are negative and to push people towards the flourishing side, and how those two are different. So there's a little bit of teaching, but much of what we do is actually incorporated into day-to-day practices that are trying to develop gratitude and hope and self-efficacy and resilience and optimism, all those kind of things. And then the last pillar we do is leadership. And I think that's one of the big surprises I've seen. Medicine has always had leadership as part of faculty development, but it's always been a solo process. So your leadership is there for you to get better at what you do and to move up in whatever you're trying to move up in. It's not been looked at as a vehicle through which one could really push wellness. And I think that's been a big surprise for us, that we've changed our leadership courses to teaching our faculty how to lead in a way that the residents feel really supported and that really pushes their well-being. And we've actually found that it pushes the faculty's well-being. So as a side effect of that, they learn their own ways. And so those are the three pillars we use. And it's really become quite successful for us to look at things on those three pillars. And then we actually look at how do we fix the negative in each pillar. Like, for instance, there may be a toxic personality, right, from a leadership standpoint, and you have to fix that problem. And then simultaneously, how do we push the things that are helpful, right, in those three pillars? So I would say it's been remarkably successful, but it's a completely different way of looking at it than I would have looked at it from 5 years ago, or maybe 10 years ago, where it was all about ice cream socials and how to, what I call the wellness 101 model, which is, let's do another lecture on resilience. Let's find a TED talk to listen to and teach people how to meditate. And I'm not trying to diss any of that stuff, but we've got a whole different approach. And I would say that's mostly because of what you guys have brought to us, and would never have guessed it 10 years ago for sure.
The next piece about your second pillar that I'd like to hear a little bit more about, because it's exactly where law firms are wanting to go. It's the figuring out how to integrate it into everyday practice of what we do. Like physicians, lawyers are very busy, and so it's hard to get people's attention and investment when they feel like they're having to do something extra.
We do have the advantage probably over a lot of law firms in that residents are required to attend a half-day didactic for us. And so I've got a captive audience that one could do a pedagogical style approach to, we're going to teach everyone resilience. But again, I think that's probably a completely crazy way to teach resilience, to just do lecture after lecture after lecture. Well, let me give you an example. So we, in the middle of that, the beginning of our didactics, we have a thing that has come out of positive psychology. You'll know it's what went well. And so back in 2016, before we started residence, we decided we would do this thing called What Went Well. And it was just the beginning part of all of our didactics. So every time we start in our didactics, we start with this What Went Well. And it's actually a very shared social experience. And it's become actually to a point where if I don't start it, for some reason I forget and I come in, the residents will interrupt me and say, wait a second, wait, we got to back up because we didn't do what went well. And so what that's about is literally, I guess there's two parts to it. The first part is that we kind of go around the room and people just identify things that went well the last week or so. And what's wonderful about that is that in medicine, at least, I don't know about law, but in medicine, we're very focused on what went wrong. So we have morbidity and mortality reports. We have 72-hour callbacks for emergency medicine. Boy, we do that up and down and sideways. And everybody gets to hear all the bad things that happen, complications that happen with your procedures and so forth. And I like this because it at least gives some voice to the things that went well. And so it helps with the in psychological capital, you have the hope, self-efficacy, resilience, and optimism. And it actually helps with all 4 of those. What's remarkable is that the third years, for instance, will say something like, oh, I floated my first transvenous pacemaker, which is a little bit of a tricky procedure for us to do. And the first years are listening to the third years thinking, oh, okay, I'm going to get there someday. I'll get there. And the third years are optimistic because they just figured out that they can do this on their own. So it's not that hard. They're going to graduate and go off and do it. And the sense that they're growing, that they literally can see people as they call out each of these things that are improving, they're growing, each year. And so it hits all of those things in the psychological capital world. And that's the first part. The second part is we actually have taught everybody active positive responding in a very deliberate way. And that's simply, I mean, it's a bit jargony in many ways, but it essentially is when someone on the team brings something forward that's kind of a positive thing, they make what some people would say a bid for attention. They say something. We teach people the active part, which means you put down your phone, you turn around from the keyboard, you square yourself to the person, and then you say something really positive. That's the active part. And then the positive thing. So as a good example, in what went well, someone may say, hey, I did my first lumbar puncture on a baby today. And you'll hear everybody, now it's virtual, but when people were in getting together, immediately people would start this active positive responding. They would turn and say, oh, that's fantastic. Did you do it on their side or did you sit them up? How did you do? How did it go? And it becomes this contagious positivity. And now on Zoom, we see it in the chat, right? So someone will say that and then the chat box starts just lighting up with, fantastic, how'd you do it? And so forth. And so that takes very little time. I mean, it probably takes about 15 minutes out of our didactic, and yet it hits all of those things. So I could do a lecture. The residents do have a little tiny, it's a self reading exercise. They do a little bit on what went well and that, very little on the didactic side. And then we hit them with it every week. And we talk about it. And when you can feel the room growing positive, like you can almost just feel it as someone watching it, we'll point that out. And we'll say, do you notice the positive emotional contagion here? Because what we're really trying to do is not just have them feel okay in residency. I would love to have them finish residency with a skill set of things that they should take with them into their practice, either for themselves, just to go off and do that, or even better, go off and teach others how to do some of these things. So that's just one of our approaches to kind of that, how do you teach that middle pillar of resilience, is you teach people through those exercises of trying to focus on the positive, learning how to reinforce the positive, recognizing the hope, and we'll break it down into that whole hope, self-efficacy, resilience, and optimism components occasionally. We'll just point that out.
Do you have an orientation when the residents first arrive that includes a well-being component?
Yeah, we do. And I do that, and I do it both for the entire institution, but also for my individual program. We have a block set in, and this may be another advantage we have. We have a 4-week block where the residents do a little bit less clinical work. And one of the things they do is they work through this guided curriculum on well-being. And it includes a lot of the positive psychology stuff. It does include also some suicide prevention stuff, and we have them explore certain apps on their phone that people can use if they're in the suicidal stages of depression. But a lot of what they're doing is much more trying to understand the shared beliefs and shared values. So I said earlier that we really favor culture over curriculum, and culture requires those 3 things. It requires shared beliefs, shared social values, and then shared social practices. The social practice is that what went well, for instance. But they do have to at least have some sense of why are we doing this, and what are we hoping to gain from it, and is it valuable? That sense that again, that's what happens when I forget and I'm moving on to something, and they're like, stop. We find this valuable. That's that shared social value in what we're doing. And so they do have a little bit of curriculum that they go through, at least in the first year, and then we just hit them with it day by day rather than some sort of a read this chapter all the time, every couple months or something. I would never want a resident to say that they have to suddenly stop and do some sort of an online course on positive psychology for an extra hour, right? That would just be that would not go over well, even if it was a really good course. They would sit there and grumble about, why am I doing this thing for an hour? I could be sleeping or doing something else. So we integrated in with a time neutral approach.
And you mentioned earlier Perma, which is Marty Seligman's concept of well-being, which is positive emotions, engagement, relationships, meaningfulness, and achievement. I'm curious, where does that come in? How do you integrate that?
Yeah, so that is part of our little curriculum we do. We talk about that both when residents first get here, and we talk about it as a very high, 30,000 foot level look at what does it mean to be well. And I love the idea, my background was in clinical psychology. And so back then being well means, you're not depressed, anxious, have suicidal thoughts and so forth. That is such a limited view. And it's unfortunate that I think that a lot of us would go there that, okay, we just got to fix the burnout. So we really want to push them to think, well, what is it that overall, over the entire course of your lifespan, not just at work, but at home too, would really make life worth living if you could stop for a second and go, where am I at on my life? And so we talk about each of those. And in fact, during their didactics, that little block where they do some of this work, they will identify which of those sections, the PERMA, they feel for themselves personally has the biggest impact. Like, where do they want to put their effort? So we use Perma as that 30,000 foot model, and then we often attach it back during the day, during our didactics. I might point out, hey, does everybody notice what we just did? We were just trying to really bring out and magnify meaning, because that's one of the main pillars we hit, is meaning in the sense of trying to get people out of their head a little bit in the day-to-day, task-to-task things that we do, especially in emergency medicine. We're just going from one thing to another. And it's really, we have found that it's so important to have meaning integrated into your day-to-day work, not just, every once in a while. And so we will kind of poke people occasionally during their work shifts and talk about meaning. And we teach our faculty how to do that and so forth.
And we'll talk about meaningfulness in a little bit more in a bit when we talk about going forward. But I wanted to pause for a minute on the third pillar, which you mentioned, which was leadership, which is really exciting for me to hear you say that you're already working on it. It's an area where I think a lot of law firms are talking about right now, understanding that that's such an important component. Can you tell me a little bit about what are you doing already? Is that didactic or practice oriented?
Yeah, so far we don't teach our residents specific leadership styles. We're actually focused on our faculty, since the faculty are interacting. And just so people are aware, what happens in our training programs in general is that the residents go see patients and they come out and they present that patient to the attending, and together we come up with a plan. And I'm sure in law there's something like that where you're presenting to someone who's higher up. And so it's a very nerve-wracking time sometimes for residents. They're coming back and they're saying, for instance, someone comes to the ER with some chest pain, and the resident may come back and say, oh, I think this person should be admitted to the hospital. And the attending may disagree with that. And how that interaction goes is so pivotal to what happens at that moment in terms of the resident's well-being. And so we're teaching our faculty very specifically, both in didactics, like we'll teach the faculty, why is this important? And then we'll role play and teach the faculty, how do you deal with that gap between the resident wants to do X, but I want Y? And in this example of a chest pain patient, the resident could say, I think this patient should be admitted to the hospital. And the faculty member could say, no, just get a second blood test. If it's normal, send him home, and then walk away. And that would be a horrific way to deal with it. And that happens all the time in medicine. And that little sense of, okay, I guess I'm just a lackey. I'm going to go order another test. What I thought doesn't really matter. I don't understand why the attending wants to do that. I don't get this, but I'll just drive on and do this thing that the person wants me to do and discharge this patient. And it's a horrible lost opportunity, both educationally and from a well-being standpoint. So for example, we'll teach the faculty now to say, okay, so you want to admit the patient to the hospital. So you think their risk of a heart attack is higher than 3 or 4% or something. So let's do some work on that. And why don't you go on your computer, and we've got some calculations we can do to say what your risk is for a heart attack. Why don't you spend a couple minutes doing that, and then come back and talk to me. And the residents will go on the computer and put some variables in the computer, and the computer spits out essentially the patient's 1% risk, much lower than what they thought. the resident comes back to us and says, you know, I think the risk is about 1%. And then the faculty says, so what do you want to do? It's really important, those phrases. What do you want to do? And they'll say, well, I think they can probably go home. And then we'll teach them to not just say yes, say, okay, if you want to send them home, let's do that. Because now you're in alignment. Attending wants to send them home, resident wants to send them home. And so now the perception, at least, and the feeling that the resident gets is they've learned something. They've learned this, approach to help on the technical side of who gets to be admitted and who goes home. But more importantly, they feel like what they've decided to do is what's actually happening. And it's this autonomy level versus the, no, don't do that. Just do this. And it's remarkably powerful. It's a little hard to teach. We're finding, sometimes the faculty are off in their head doing other things and they miss the opportunity. But we've made a lot of progress with that. And I think the faculty notice it too. And they notice how helpful that is.
So how our relationship has progressed as we started working together several years ago in kind of creating an outline of an initial program, and then launched a study that's been now going on for years to identify factors that we think are related to alleviating ill-being and fostering well-being. And we've been figuring out some things that we think will be great to focus on. So can you talk to me a little bit about now where are we, from your perspective in this study, and where would you like to go next?
Yeah, so I mentioned earlier the size of HCA, the group that I'm with. So we support the largest number of residents in the U.S. and by far, and so we have an opportunity to make some important interventions and to invest funds into important interventions. But of course, before we get there, I really think it's important we understand the variables that are impacting those outcomes that are important for us. What we did, and is Claremont and HCA together 3 years ago now, I guess we're at, started a longitudinal something. It's been going on quite a while. So we started a longitudinal study, which I think was very important, first of all. So, we're talking about causation and trying to understand variables. So there's a lot of cross-sectional data out there. People do that because it's simple, it's easy to do. I think one of the things that was really quite important to do is that I think you convinced us, don't just measure the negative outcomes, which would be very typical. I think 90+% of all the studies out there, almost 100% of studies in medicine, look at depression or burnout. And I think that's important. I wouldn't negate those, but adding the positive outcomes, which for us, we used engagement, we used something called motivational harmony, I think on the second year one, but some sort of positive outcome was really quite a game changer for us in many ways. And so we did this study over 3 years. We have 9 waves of data at this point. We have 2 years pre-COVID and then a year after COVID hit. I think when COVID came along, it gave us an opportunity to see what would happen with the relationships between certain variables and outcomes under stress. So I think you'd ask where we're at. I think we're at a point to take what we've learned from the studies and have a pretty good shot of interventions with a good confidence that the relationships between variables that we found are likely to be true. And that way we can, have more confidence in spending a fair amount of money to intervene.
Yeah, why don't we identify what the variables were? Which so why don't you go ahead and say what they are?
Yeah. So, the outcomes, again, depression and burnout, of course, it'd be hard to study that in medicine without studying burnout. That's just pretty ubiquitous. And then the other outcomes was engagement. And in terms of the predictors, this is where, you probably had a lot of impact on us with the positive predictors. We did measure social support in the first year because there's just so much evidence that impacts depression in particular. And so we measured that in 1 year. And then psychological capital, and that's, we talked about that earlier. Then the 2 big ones that I think are more contextual, which are important, that really aren't measured out there, we measured meaning, or the perceived meaning of work, and we measured supportive autonomy and leadership.
And the other outcome that I'd like to note, because I think it'll be interesting to law firms as well, is we were also measuring intent to come back, that residents don't have to return to their hospitals after their residency.
Yeah, that's a good point. Yeah, so excellent. Yeah, that was, I'm well aware that big organizations have to look at the bottom line sometimes, and money and so forth. And so well-being has this big metric black hole in it. What's the cost of not having well-being? Nobody measures it. Nobody knows. It's really intangible, other than we've got some rough estimates of what turnover costs. And if you can get somebody who stays within the training program, leaves the training program and comes back, that saves quite a bit of money in training. And then if you can take the same variables that we used in our study and apply it to, say, nurses, where nursing turnover in the US is pretty high any one time, and suddenly have nurses not leave because they actually enjoy what they're doing and where they work, the savings are really impressive. So when we first started this, we wanted to measure this tendency to want to stay within the same system, partly to help, I think, convince people who actually make the decisions about money, where would it be a good place to invest some money.
Findings were what we expected. I think the only question was social support wasn't as strong as we thought it would be, but the others were: psychological capital, meaningfulness, and autonomy supportive leadership. Well, we were pretty excited about, right?
Yeah, so what's interesting is we had both cross-sectional results and longitudinal results, and some of those differed a little bit in some ways, and I think that was really important. Measuring what predicts change in trajectory of people's depression or burnout or engagement is really helpful, because that's a more causative connection. So we saw that meaningfulness and supportive autonomy leadership were probably the two of the biggest predictors. Engagement, which is technically an outcome, when we put that into a model to predict who will stay with our institutions, this propensity to stay with your employer, essentially, engagement was the number one of all of those things. So what that tells you is if you can make people feel more engaged at work, they're more likely to want to stay with you. Well, that's not exactly rocket science, but it was nice to show that in a study. And then what do you do to help engagement? Well, you get leaders who people enjoy being around, and you reinforce and magnify meaning. And then kind of on another side of that's that second pillar, you teach people the psychological capital ability that helps prevent a little bit on the depression side.
Based on the findings, where are you hoping to go next in developing the program?
I think we have a pretty reasonable approach right now to some of this, but I think there's a lot more we could be doing. And I'm not sure I can teach others yet how to do this well. So we have a plan to bring in a couple of folks two of the folks that actually developed self-determination theory, and then one of their colleagues here. They're going to be coming in here in the fall, and we have some funding to do a feasibility study on at the hospital level on what do we do what happens if we teach everybody some basic supportive autonomy leadership and some other self-determination model variables, and can we make a difference? It's quite aspirational, but I think it's doable, and it's a completely different direction than we've been going in the last 20 years, which is what we need, because we made no gains pretty much over those 20 years. So big plans, I hope.
The person you're referring to is Dr. Rich Ryan. He is one of the creators of self-determination theory, which was the foundation of the measure that we used for autonomy supportive leadership. I think what we're actually going to do is an intervention that's all need support. Autonomy tends to have the strongest relationships, but they're all really important. And so that's really exciting. And that was the basis of my book, Positive Professionals. I considered that one of the foundations of positive law firm. So for me, it was very exciting to see it popped the way we thought it would. It popped the way we hoped it would in the data. And so I think it's going to be exciting to move forward and really look at how leaders shape cultures. Because just like you mentioned, that I think when the well-being program started in medicine, they're more like meditation and ice cream socials, which have their place. And we're now moving to a more complex understanding of what's going on in the culture, and leaders being culture shapers and experience shapers are really, the key to that. The other thing that you mentioned that really popped was meaningfulness. Do you have any plans right now, or are you doing things already that really focuses on fostering meaningfulness?
Oh, yeah. So I think that's probably the easier of the two in many ways, at least in medicine, right? So we're very lucky, of course. Emergency medicine, we have a lot of opportunities for that, and we teach it in two. We don't teach it. We bring out meaning in two different ways. We do it weekly in our didactics. And so when somebody says, what went well? Oh, I did, so-and-so did a great job floating a transvenous pacer. We talked about that earlier. One of the things we teach people in the faculty side to do is to recognize the difference between an achievement and the importance of the technical skill of putting in a transvenous pacer. That's great, good for you. You've advanced, your competency's increased, you've been able to do it. That's wonderful. And typically and historically in medicine, we stop there. Good job putting in that transvenous pacer, way to go, you're growing. What we failed to do is say, and by the way, the human being, Mrs. Joan over there that you just put the pacer in, is now going to live and be able to see her grandkids in Thanksgiving and Christmas. So good job, take a moment, take that in, and then get back to work. That change that we do now is really remarkable. And so we've taught all the faculty to remember to connect both what we kind of do naturally, the great job, good pickup on the EKG, that it was a heart attack, way to go, and add the little bit of, by the way, don't lose touch with the fact that EKG came off of a human being who has families and emotions and dreams, and you just made a big difference. And so we do that both in our what went well and also in our day-to-day work. And that's where we avoid any extra time. I mean, we're really talking about 10 seconds. I mean, just adding a little bit of, looking down at the patient's wrist that has their name on it and just specifically saying, well, Mrs. So-and-so, is going to go home now and do better because of what you've done. And, connect the fact that you missed all those parties in high school and in college and in medical school, and recognize where that got you, because now you just made a difference on her life and her children and everybody else. And so just learning how to make that little pivot is really important. And one of the things we tell our faculty is get over cheesy. So, people go, oh, that's so cheesy. Well, wellness goes right through Cheesyville, and there's no way around that. I mean, you're just going to have to embrace the fact that, if you find that cheesy, I'm sorry, I don't know what to tell you. You just have to sit there and say at some point, let's recognize the fact that these are human beings and that what you do makes a big difference in their life, and be okay with that. And I think that's made a really big difference in our residents. So for us, for instance, during COVID, we had no dip in our resident well-being compared to everybody else pretty much in the country. And I think that comes from the fact that we'd already built over 2 years before COVID hit this underlying program where people connected their well-being not to social events, which went away with COVID, and suddenly everybody's program crashed with COVID because now there was no more ice cream socials to go for, and that was their entire wellness program. Our wellness was based on leadership and meaning, achievement, and so forth, which didn't get affected by COVID. If anything, they increased. And so we saw in our research that as you get more stress, for instance, autonomy, supportive leadership increases the tendency to see that event, that stressful event, as a positive versus a negative. And so with COVID and the way we push meaning and the way we push leadership, I think we did really well and compared to other residencies out there. And that's just all because of you and what we set up several years ago. So Anne, by the way, what you did had a big meaning on people, because they were not out there. They're doing great in residency. They're taking care of other people. They're doing a good job.
I will take that and thank you. That does create meaningfulness for me, but I also just want to say congratulations. Like, that is an amazing result of what you've done, that your residents have made it, hopefully getting through the pandemic with still high well-being. That's just really incredible, Greg. Good work.
It went up, actually. We went up a little this year compared to last year. Amazing. And I think that's just that effect that, it really matters now. That meaning goes even higher, the meaning.
It becomes more salient. Yeah.
Yeah.
And that is not true in the legal profession. I would say well-being has not gone up. And that's really kind of the place that I think that I'd like to wrap this up, is just thinking about, from everything that you've learned from the time that you've started to now, and your little bit of knowledge of the legal profession from your wife, do you have any advice to the legal profession on the kinds of things that they can do?
I'll say it all with just very humility. I'm not a lawyer, so take whatever I say with a grain of salt. And I do know a little bit about it. It's a little bit of a rough world sometimes. I guess I would say the concepts that we've been talking about, leadership and meaning, I see no reason they wouldn't work the same way in law. I think for emergency physicians, obviously, it's somewhat more palpable to us immediately in front of us of what it is that brings meaning. I would imagine the same thing happens in law. And I know that's your expertise of how do you magnify meaning. I think if you look for it, you find it. And if you don't look for it, you're not going to find it. And so I think I would probably do the same thing we're trying to do and move away from focusing on ice cream socials and bowling alleys and barbecues and things, and really look at some of the more workplace environment factors the same way we have. I would expect it to work equally well. It just may take a little more sophisticated techniques to find the meaning, I suspect, than what we have to do. Overall, what I would say is the focus on negativity and the attempts to try to fix the problems that are out there that's important, but I hope they don't just stay on that part, because I'm aware from my own experience, limited experience in law, that there's a lot of negativity, it seems, and it's important to fix that. But hopefully you can find leaders that really bring out the positive side.
Thanks so much, Greg. This has been so helpful. I have learned a lot about what you're doing, and I think it's going to be really beneficial to the folks in the legal profession who are trying to build well-being programs. And I look forward to continue to working with you and see what else we can build.
Wonderful.
Thanks so much.
You bet. Take care.